This is one of the emergent floor issues kind of lecture. I'm the one that's going to be giving it today. So let's get this thing rolling. All right. So this is primarily kind of geared towards the interns because I know that when I was on nights or when you're, on call and you're getting a bunch of phone calls, you don't always know what to do. So this is a picture, if you're on nights, you're like resting, sleeping, things have gotten nice and slow. Maybe you're watching a good show. Well, you get a picture like this. All right. You get a pager and you get told that, patient is really hypotensive. They just tell you that their maps are like 59 and that you should call certain number to figure out what the hell is going on. You were happy because you were watching Say Yes to the Dress, and you were having a good time. You were seeing this lady here with a upside down coffee filter dress going on, but now you got to go shut this off and go investigate. All right, so this is what the lecture is all about, So I'm going to discuss basically how you should approach hypotension, okay? Some of it, I just want to kind of make this sort of informal. Feel free to ask questions. I'm just kind of fiddling with my screen to see everybody, but want to keep this informal so that you guys can actually take something from this. I know if a long lecture, then you wouldn't be able to, everybody would kind of zone out, but the first thing you need to think about is like, what is hypotension, okay? So the very first thing is like hypotensive is if a patient's blood pressure, like systolic, is below 90, if their MAPs are below 65, or if they have a relative drop in their systolic blood pressure by more than 40 millimeters of mercury, okay? Just because they're hypertensive or even normotensive doesn't mean that they're not going into shock, right? And so early recognition of this is really important. And we'll kind of discuss, what sort of things you can look for. Even if the blood pressure is fine, what sort of things should trigger you to think that something is not right, and I need to be a little bit more aggressive in my management, okay? So the first thing I want to kind of start off by talking about is just orthostatic hypotension. And the reason I'm starting off talking about orthostatic hypotension is because it's the most common cause of hypotension that you're going to see in the inpatient setting. All right. Generally, I mean, I think most people know the definition of orthostasis, right? Which is if your systolic blood pressure drops by at least 20 millimeters of mercury, or if your diastolic drops by 10 millimeters of mercury, generally after like changing positions, right? So if you were sitting and all of a sudden this person kind of stands up really quickly and then they drop their blood pressure or they become really tachycardic, they could be orthostatic. So general kind of stepwise approach to this is first, ask if they recently got any medications. Did they get any sort of antihypertensive medications? Maybe they got an extra dose for some inexplicable reason, or they got a bunch of these medications all at the same time, right? So if that's the thing that's going on, then obviously the first most simplest approach is that you just stop the medication. All right. And then in the meantime, depending on which medication they were given, you just keep a close eye out on them and give them some fluids, try to get their blood pressure back up. So that's, the first step, get rid of the offending medications. If you get rid of the offending medications and they continue to be orthostatic, then you increase the salt and water intake. It depends on the outpatient setting. You would just tell the patient to have more fluids and eat a little bit more salty food. But in the inpatient setting, normally we're just going to give like normal saline bolus or normal saline fluids, and we'll just kind of start that up, especially if the patient appears clinically dry. The other thing that like generally we always recommend to all the elderly patients, especially ones that we think are, high risk for getting orthostatic, is you just tell them to wait a little bit before they change positions, right? They can't just like jump out of bed and then start sprinting again. So, tell them, take some time, sit down, wait for 5 minutes, then stand up, then, kind of make sure you're steady on your feet, and then you can kind of go forward with things. Weirdly, actually, the recommended salt intake is around 6 to 10 grams of salt per day. That's the one that's recommended. And it tells you to kind of be careful with CHF patients, which is obvious. But I mean, this one to me doesn't make too much sense because most of your patients that are going to be orthostatic are going to be old. Most of them probably have underlying heart disease anyways. But still, just something to kind of keep in mind. The other thing you can tell them to do is just take part in like cardiovascular exercises, right? Even if they can't run or they can't like lift weights or something like that, like there's pool exercises. Encourage them to go to like physical therapy as some form of exercise just to kind of get their conditioning better. And obviously compression stocks and abdominal binders. So just, more so conservative ways still to try to avoid starting them on medications and things like that. Try to avoid medications as much as possible. So tried some of these more kind of simpler approaches first. In the inpatient setting, especially, if they continue to not have an adequate response, then you can start using like medications. I think everybody is the most familiar with like midodrine. I didn't see, like I just saw like droxidopa and then fludrocortisone. I didn't know that they were part of our approach to hypotension as well, but midodrine is the one that I think most of us are very comfortable with. And we're going to see midodrine kind of come up throughout this lecture. So if, you gave them fluid resuscitation, they appear like, they're not dry anymore. We also increase their salt intake and they're still hypotensive. Then what you can use is midodrine, which is an alpha agonist, right? And what that's going to do is cause the blood vessels to kind of like clamp down, right? And that will artificially or pharmacologically increase their blood pressure and peripheral vascular resistance, cause them to not become so hypotensive and then, faint or anything like that. Some things to kind of watch out for, you have to be careful in patients with severe heart disease. You are increasing the peripheral vascular resistance, so then the heart has to press against more resistance. So you just have to be a little bit careful of that. And it can also lead to like urinary retention. Then there's droxidopa, which I don't think many of us use. It's a norepinephrine analog. It can cause headaches and nausea, but I haven't really seen it used in the inpatient setting. Maybe some of us will be daring enough to try that next time, especially if somebody's still hypotensive despite midodrine. And then the last one that you can also use is fludrocortisone. That's a mineralocorticoid, causes increased kind of like salt retention, fluid retention, and that's another way that we can kind of do it. Same thing with, increasing salt intake is that you got to be careful in patients that have CHF because you could worsen their CHF condition, right? Okay. So now that we're done with orthostatics, and I purposely did that ahead of time because it's a pretty boring condition. It's very frequent, but most of us encounter it very frequently. We know what to do. So now I'm going to go and shift focus more to like the inpatient side and more to what, your approach should be. And I'm going to think about this as if like we're on nights and it's slim shift and you're the only one that's going to managing everything. Okay. So you don't know most of your patients. So the first thing that happens is that, you get a phone call saying the patient's hypotensive, you call them and you're on the phone with your nurse, right? And so you're going to ask them like, okay, couple things. What is the blood pressure? You told me it maps to like 59, but what is the actual blood pressure reading right now, right? Somebody whose blood pressure is like 95 over 60 demands a different type of attention than somebody whose blood pressure is like 70s or 60s. So just ask them like, what is the actual blood pressure? Ask them, how does the patient look clinically to you? Do they look comfortable? Are they okay? Or are they somebody that you feel like is starting to really struggle, just feels kind of overall sick? Get their gestalt as to what's going on. And I think, to be honest, like how they're doing clinically is probably the biggest indicator to you, just because it's going to tell you like, how sick is this patient? You're going to ask them, repeat the blood pressure. Most of them have already repeated it because all of us ask for that same thing all the time, right? But just it's worth kind of doing. They'll tell you that we've already repeated it a bunch of times, like 3-4 times. It's still in the 80s. And while you're on the phone, one of the things I do is I kind of just look through the patient's chart, because most likely you don't know this patient at all, right? They're just hypotensive. So one thing that's really good to do is, and this is also kind of helps you guys understand why your notes and especially your assessment and plan are so important, because on nights, you don't know what the hell is going on. You don't know who these patients are. So, I kind of take a look at the assessment and plan, and I say to myself, like, okay, these are the problems that the patient is currently being treated for in the inpatient side. This is what's been going on. And this is, more importantly, this is what happened today, right? And then also just, I check the vitals, right? So if somebody's been persistently hypotensive, like your old ladies are probably going to be always in the 90s, your cirrhotic is also going to be generally persistently hypotensive, and that's kind of where they live, versus if somebody was like blood pressure was like 140 and all of a sudden he is super hypotensive, that demands a different level of attention, right? So you're trying to get an idea of what's going on with the patient, who this patient is while you're on the phone with them. Okay. And then, at least as an intern, I used to do this all the time. Now my approach has kind of changed, but you almost always go to bedside. Take a look at the patient, lay your eyes on them, and just figure out for yourself what's going on. Let me see. Yeah. So again, your goal
One
when
thing,
you go to
Akil, one
yep,
thing, like when you go to the bedside, I don't know if you're going to touch base on it or not, is to make sure that the blood pressure cuff is appropriate to the patient's
yep,
size. And
yep.
number two, measure blood pressure on another arm, on another leg, or just to confirm like more than one site has the same blood pressure reading.
Yeah, so that's exactly what I was going to say is like, the best thing that you can do when you go to bedside, especially if you're concerned about somebody, is that you check it yourself. And this is both like when you're getting admissions from the ED or when you're just overnight, make sure that the cuff is right size for the patient. Make sure that, it's not too loose. Check both arms, actually confirm like what's going on. Is it just an isolated reading or is this persistently? If the patient is really hypotensive, then you got to do something. If they're the blood pressure cuff was like wrong, you use the extra large on a super skinny lady, of course it's going to be hypotensive. The other thing that you kind of think about is like, and obviously I'm putting it down in a list, most of you guys are probably doing this almost automatically, is that you go to bedside and you look at the monitor. You look at the monitor, you see what their vitals are, right? Are they tachycardic? Are they bradycardic? What is their oxygen saturation like? If they don't have the monitor on, that little thing that I think I have a picture of it. Yeah. That little thing that's kind of stuck to their chest, kind of look through the several leads. You don't have to just stick with one lead, go through several of them, see what their tele kind of shows. Do you have a concern for an MI? Do you have a concern of like them having some sort of underlying arrhythmia going on? And then if the patient is really hypotensive, and this you will see all throughout, is you have to stabilize them. Before you start thinking like diagnosing them or anything like that, if they're genuinely hypotensive, then you have to start stabilizing them right away. Okay. So start with your ABCs. Are they able to protect their airway, right? Or are they super kind of drowsy or not? So are they able to protect their airway? Are they breathing? If so, how many times, right? And then obviously we're discussing circulation, so they're probably hypotensive. You need to also take a look, right? See if they're clinically dry. One of the things that's a safe bet is like you can always, because you guys will always have questions like how much do I fluid resuscitate this patient? They have AKI, they have CHF. I don't want to volume overload them and then cause more problems. So my approach is, and I think every senior has their own approach, but like my approach is you're probably not going to hurt somebody with a 500cc bolus. It's very minuscule, and you'll see if you can get some sort of response in their blood pressure. So you can start fluid resuscitation, put the orders in. This way the nurses can kind of get the bag and bring it to bedside. The other kind of way, which is cheap and dirty, but it almost never works, is you can just lift both their legs up, right? And that will also give them a fluid bolus. It never works because patients' legs are super stiff. They always complain of pain, so it never really works out. And also, like if they're in some sort of an arrhythmia, especially if it's like a tachyarrhythmia, you're gonna consider cardioversion. At this point, you have some sort of tachyarrhythmia with hemodynamic instability. Get the pacer pads on and shock them. I have pressors in question marks because depending on how the patient responds to the fluid resuscitation, you're either going to start midodrine or you're going to like start levo through peripheral IV, and then you're going to call ICU right away. And then once you've kind of stabilized the patient, then you're going to start to think about like, what is actually going on? Why is this patient hypotensive? There's many different causes of hypotension, and we'll kind of touch on them, but then you can kind of think about what do I need to do next? And if you're ever worried, you can call your senior. And if your senior is also worried, they'll probably call their attending or ICU or something like that, especially on the floors. So this is kind of the thing. I know it's weird. I had to look for pictures of Foley bags and urine. But this is a really good way to kind of, like when you go to bedside, right, there's things that will tip you off that something is not right. So even if they are like normal tensive or something like that, you know, and you gave them fluids and they responded to it, something that will tip you off like something is not right is, we already touched on like what's their heart rhythm is. If they're tachypnic, breathing really, really quickly, 30, 40 times a minute, something is wrong, right? There's a reason they're breathing that fast. It could be a PE, or it could be just underlying metabolic acidosis that's kind of brewing, and they're just trying to breathe it off. So think about that. You can ask your nurse for like what their urine output has been like in the last hour, 2 hours, and they'll give you a general idea. If they don't know, that's fine. You know, you can take a look at their Foley bag, and that's why I put it here. I use this pretty often now in the ICU, is just kind of seeing like, are they having urine output or not, right? So if they have this skimpy little dry, super dark colored urine and it's minimal output, they're probably dry as hell. You know, they're either going to respond to fluids or they're not, but I know at the very least that the kidneys are not being perfused probably very well. Versus if they're putting it out really, really quickly, then two things could be going on. Either they're adequately fluid resuscitated, or we've been just over diuresing the shit out of them and now they're dry. You know, we did this idiopathically, or we did this ourselves, right? So oliguria, mental status changes, of course, and then you can press, like put your hands on the patient's skin. You know, think about like, it goes back to basics. So if they're warm and they're hypotensive, right, you're thinking of possible sepsis, septic shock kind of brewing. If they're cold and hypotensive, then you're thinking they're just decreased volume, right, and their peripheral vasculature is clamping down. And then hyperlactatemia, you're not going to know that unless somebody drew the sepsis labs already, but that could just be another thing. And lactate, you know, is a sign of just decreased perfusion, you know, or just not meeting the oxygen demands that the tissue needs. So always think about these things. Anybody have any questions so far? I know I'm like kind of speaking fast. All right, so it looks like everybody's good. Good stuff. Okay. So this is probably the biggest thing, and I really want you guys to pay attention to this, is when you go, especially on the floors, you know, you got to see like, is this an emergent case or not, right? I keep repeating the point, like look at their maps, but it doesn't matter. And we talked about looking at them clinically. We discussed their hospital course. But you also think about like what risk factors that they have, you know, that could also point you to the etiology of this shock itself or hypotension, right? So this old grandma, sweet lady, you know, she's a post-op patient. She just had her hip replaced. She's at risk of like either a PE or she's at risk of some sort of underlying bleed, right? So that's probably what's going on with this patient. This person is a lady that's cirrhotic, right? So cirrhotic patient is going to always be hypotensive, you know, but, you know, if they look like they're not doing well overall, or they just had a change in their mental status, or that you had some sort of change in their blood pressure, then you think to yourself, like, is this SBP? You know, I want to cover them empirically with antibiotics and just kind of get ahead of the curve. And we're going to touch base on sepsis and why it's so important to be quick with antibiotics, especially if you think some sort of infection is going on. And then there's this guy, right? He's super healthy, young guy. He's living a good life. He just so happened to be in the hospital for some stupid reason, and now he's hypotensive. You know, if I was a betting person, I would think like, this guy, he just got too many medications or something like that, right? He most likely doesn't have some very, very serious thing going on. Okay, so we discussed this. First steps, ABCs. The other thing that I'm starting to realize now is that you need to make sure you have access. Okay, so you go to bedside, you realize, shit, I need to give fluids, I need to get things going, you know, but you can't give fluids without access. So ask your nurse, you know, how many, like, what is this patient's access like? Do they just have one peripheral IV to what's going on? And that will also help you because some patients will need larger fluid boluses going at a much quicker rate, you know? So just to determine like what kind of access do they have. Start resuscitative efforts immediately, IV fluids, or if you need pressors, start them right away. Don't hesitate. You know, you can run levo through the peripheral IV. It's all right. You know, it can handle for a few hours. And then also like be liberal with you don't have to be conservative with the fluid resuscitation. If somebody has CHF or AKI or something like that, and they're in sepsis or septic shock, like you need to give them 30 cc's kg per body weight, right? And the logic behind that is like they've got this underlying inflammatory response or infectious response that's going on, and all of their blood vessels are now dilated. So yeah, they have CHF, but you have all of this kind of tubing throughout the body that's just empty. So fill it up, you know, and then we'll figure out everything after. But right now, your goal is to stabilize the patient. And then get labs, chest x-ray, EKG, things like that. So just to get a better idea, you know, chest x-ray will tell you if there's some sort of you know, some sort of process going on. Is there pneumonia or something like that? And EKG can tell you if there's some sort of an MI, and then labs for troponins, BNPs, stuff like that. Okay. Any other questions so far? All right. Sweet. Either I'm doing a great job or I've lost everybody already. But I think I'm doing okay. So we've, you know, I've kind of hammered in the point that you go to bedside and you stabilize the patient first, and now you're going to go down the diagnostic pathway. Okay. So risk stratify this patient. Obviously on the floor, we used to like sometimes, especially overnight, you get a bunch of like junk calls, you know, so you can almost become apathetic to something that's actually going on until it becomes too late. So, you know, don't just become kind of willy-nilly with it. Really go down and always go through the process. So ask yourself, like, you know, is this somebody that needs a higher level of care? You know, listen to their heart and lungs. Do they have diminished breath sounds in one lung field, right? It could be a tension pneumothorax, you know, if they have tracheal deviation, JVD, things like that. Cardiac tamponade, really, you know, you're looking for a clinical picture of somebody that's undergone recent surgery, or, you know, they had some sort of valve repair or something like that, like an aortic valve repair. Somebody that could be bleeding, right? Somebody that could be bleeding around their heart itself, right? Anaphylaxis, most nurses will tell you, you know, you're looking for hives, some new medication that was just started, and they're gonna complain of like difficulty breathing and things like that. Sepsis, I think we're all comfortable with, or we all kind of get the most amount of exposure to. Adrenal crisis, not so much, right? So adrenal crisis, you know, if a patient has a history of like chronic steroid use, right? Or they already have a history of adrenal insufficiency and they're coming into the hospital and now they're sick, right? So their body can't respond with intrinsic glucocorticoid response, right? So you need to think about like, is this adrenal crisis that I'm seeing, and I need to treat them accordingly. Hemorrhage, we don't normally see. Well, we do actually, but we don't, like, there's traumatic hemorrhages and there's non-traumatic hemorrhages, right? Most of the time we're going to see like non-traumatic hemorrhages. Our most common one is going to be like a GI bleed. So a GI bleed process, you know, you're thinking of somebody probably with known GI bleed, or a cirrhotic patient, or somebody that's, you know, just recently started on anticoagulation, right? So these things are now pointing you to the fact that I think this person could be at high risk of a bleeding, you know, and I need to not only ensure that, like, here's the thing, right? This happened to me in the ICU, right? There was a patient, all of a sudden his blood pressure started to drop. I didn't know anything about the patient, right? But I thought to myself, like, I think this guy may be bleeding, right? So one of the things that you can do is that if they have like an NG tube, put it on suction, right? And that will tell you if there's some sort of an upper GI bleed going on. You know, listen to their bowel sounds, right? And press on their belly. If they're very tender, yes, you know, you have some sort of a sign. And also, like, one of the things to remember is that blood is an irritant, right? So it's irritating and it's most likely going to come out in a little bit. But if you have a suspicion for GI bleed, you know, start Protonics IV. And if you can confirm it, you can call GI as well. They will probably scope in the morning, but at least you've done your bit. And depending on how, you know, hemodynamically unstable they are, they're already aware of the patient. So they're not going to, like, you know, tell you at 6 o'clock in the morning, like, hey, why didn't you guys call us? We would have scoped this patient at bedside. They wouldn't have, but whatever. And then MI, you got to call cardio, you know, and then obviously PE we've discussed. Okay. So, you know, when you're seeing these patients, some of these patients, you know, there's things that you can do, right? As an intern, you don't want to bother your senior, you're being a good guy or girl. And if you suspect sepsis, start IV antibiotics. All right. Start broad spectrum antibiotics. Don't try to be like narrow conservative. Just throw it. Put it on. Make sure you don't miss the bug, because in sepsis, like early antibiotics, as soon as possible within the first 3 hours, and early fluid resuscitation has a mortality benefit, right? So nobody's going to fault you for being super broad on antibiotics. People will fault you on not starting them soon enough. If they have anaphylaxis, give them epinephrine.
One quick comment: make sure to bother your senior if you're not comfortable with what you're doing. You should be at bedside with you with any hypotension, unless it's the last 2 months of the year.
What he said. Okay, so arrhythmia, you go through your ACLS protocol. Fast rhythms normally get shocked, slow rhythms get atropine, and then paced. And then some interventions you can't do, okay? So if there's a tension pneumothorax, I mean, you're gonna call your senior, as Abdullah mentioned, they're there. But if they have tension pneumothorax, you're calling ICU, right? If they have cardiac tamponade, you're gonna call CVTS surgery, and then you're probably gonna call ICU. If they have a hemorrhage, you're gonna call general surgery or GI, and you're gonna call ICU. If they have an MI, you're gonna call cardio, and then you're gonna call ICU, right? And then if they have a PE, you're probably gonna call interventional radiology, and then you're gonna call ICU, right? So just these are the situations where like you're gonna call ICU or not. Is this patient going to or not? And then, as you mentioned, always call your senior. They have a little bit more experience. But yeah.
I think for tamponade, you need to call interventional cardiology.
Okay.
Because last time I called CVTS, they told me to call interventional cardiology.
I remember that. Yeah. And obviously, like, these are based off clinical suspicion. I don't think most people, when they go to bedside, are suspecting cardiac tamponade. You're probably going to get like a bedside echo or something, or you're going to look through their old echo, which is what happened when we were in the ICU and we saw the tamponade. Look through the echo images itself. It may not be commented on. It's always important for you guys to take a look at your own imaging. Jesus Christ. All right. Tension pneumothorax. I initially put it in, but I'm not going to really discuss it because I think we know what sort of things to kind of look for. But tachypnea, unilateral chest pain, diminished breath sounds, deviated trachea should make you think of tension pneumothorax. A PE, I think, is always on our differential. It's pretty common. Hypotension, dyspnea, and hypoxemia, right? So if somebody's tachycardic, having a hard time breathing, and they're hypoxic, you're going to think of a PE. And then I put cardiac tamponade here because I don't think we get too much experience with it. I'm not the greatest with echoes, so I got a solid image that's already labeled. But what we're looking at over here is the classic. You're looking for muffled heart sounds. You're looking for JVD. You're looking for electrical alternance, which you probably won't see on the tele, but just in case. And then pulsus paradoxus, right? So, and this is like an echo version of like, you being able to see pulsus paradoxus. So you can see this large amount of black, like anechoic thing around the heart. This is your tamponades that's brewing, or that's there. And then if you look, you have a reduction in your pulse pressure whenever the patient kind of breathes in, and then it goes back up when they expire. So these are things that should make you think about tamponade. If this was a flattened kind of, septum was flattened and it kind of looked like a D shape, right? Then you would probably think there's some sort of a PE going on rather than a tamponade, just as, signs to kind of look for. Okay, so I'm just gonna really quickly talk about PEs. I'm not gonna go into like deep dive detail, but just wanted to discuss some, problems that can cause hypotension, partially because everything is fluid and pressors. So I wanted to at least talk about some sort of problems. Okay. So, like we mentioned, if somebody is tachycardic, hypotensive, hypoxic, you're thinking about PE, you don't have to have all three, just if you have enough suspicion, go down the pathway, So if they're stable, I do this now very often in the ED. You do the Wells criteria. Okay, look, like pull up MedCal, put it in. Do I think there's a PE going on? Order your D dimer, and then based on the Wells score and your D dimer, you're either going to go for a CTPE or a VQ scan. If you're in the ED, you're probably going to get a CTPE. And then if they're unstable, then you call ICU, because you probably won't have enough time to do like the well score. You know, you probably won't have enough time to wait for the D dimer, or they may not be stable enough to go for their CT scan. You know, call ICU. And the reason or if you're comfortable with it, but probably are not. Because the reason you're really calling them is you want to get a bedside echo, right? That's the way you're going to diagnose this one, right? I have a high suspicion. I think this patient has, you know, massive PE that's causing hemodynamic instability. Can you please come to bedside, right? And they'll do an echo and they'll see if they have a high enough suspicion for it or not. And they'll kind of go down the treatment pathway as well. So categorizing PEs, I'm sure most of you guys know about this already. But, you know, you have, it doesn't matter about the size of the PE. It's, you know, what sort of symptoms it leads to, right? So if you have a essentially, if a patient becomes hypotensive, right? If they become hypotensive and hemodynamically unstable, it's a massive PE. It doesn't matter the size. And if they are hemodynamically stable, then it's a submassive PE, okay? And then in that submassive PE, you can break it down further into either like low risk PEs, like low risk submassive PEs, or intermediate low risk and intermediate high risk PEs, okay? So intermediate low risk PEs are like, you know, it's tiny, they're probably stable. You got your D dimer, you got your CT scan, everything like that. And you look at it and, you know, the right ventricle is not like dilated, it's functioning normally. You don't have elevated troponins. You can use the SPECI score, which is also on the MedCalc, you know, and everything is basically normal. This is just a clot that's there, but it's not causing too many problems. It's a submassive PE, just, you know, treat it with unfractionated heparin. If it's an intermediate risk PE, right, or an intermediate, so intermediate, so you're gonna have somebody that has like extensive emboli, they're tachycardic, you have signs of RV dysfunction, they have elevated biomarkers or borderline blood pressure. They're not hypotensive, they're just getting kind of softer side, you know, so that's gonna be an intermediate risk PE. The way to kind of better characterize this is like if they have abnormal function or elevated tropes, you know, then it's going to be intermediate low risk. If they have both, then it's intermediate high risk. From just, you know, my experience so far, low risk PEs, you don't really do too much about. I mean, you treat them, but it's not something to kind of like start like raising red flags all over the place for. But intermediate low risk and intermediate high risk, you really can. And I've seen intermediate high risk obviously go to the ICU as well. And then some ways to see the RV strain that I've seen so far is just bedside echoes and the CT scan itself. If you see like a fairly large dilated RV on your CT scan that looks about the size of the left ventricle, you know, that's like another way of kind of saying that there's some RV dilation. All right, so in terms of treatment, and this is, I think, what most people really care about because you want to be able to kind of do something for them, is that, again, initially you're going to stabilize them, right? It's the same thing every single time. It's not worth diagnosing and going down the pathway if the patient's dead, right? So first thing you do is you give them some fluid resuscitation. You don't want to be overly aggressive in this situation because small amounts of IV fluids will kind of help increase the cardiac index. But if you give a large fluid bolus, if like you're like, oh shit, it's a PE and they're hemodynamically unstable, and you like bolus them 3 liters, then it'll cause overstretching of the right ventricle and it'll actually worsen their overall outcome, right? So be gentle with it. That's why I say, you know, 500 cc is never going to hurt anybody unless they have incredibly bad heart failure, but 500 cc is not going to do much, okay? And it's a solid, safe kind of bed. And if they need pressors, start it, right? If just because, you know, if their blood pressure is like 50s and you confirmed it, start pressors. Don't mess around with it. And make sure they're oxygenating well. They may need to be intubated, you know, so call ICU if they need to be intubated or call anesthesia if they need to be intubated. And obviously your senior's there and they're probably going to be handling this. And then you start unfractionated heparin, you know, so if, so you give them fluids, they're okay now, and, you know, you'll start, and you think that it was a PE, you're going to start unfractionated heparin, you know, pharmacy dose heparin, and then get the study to confirm your diagnosis. If they're too unstable, then call ICU, bedside echo, get things done. Okay, any questions? Doesn't seem like it. I'm speaking a little bit fast, but all right, sounds good. Good stuff. Hemodynamically stable patients, again, you don't want to give them too much fluids. Anticoagulation is really like, depends. If you have a high likelihood of PE, then just start your heparin. If you have a low or moderate suspicion of PE, then you may be able to play it kind of case by case, especially if they have a risk of bleeding, right? So if they have a risk of bleeding, but it's a very high likelihood of PE, then you really got to kind of like weigh your pros and cons. At this point, you're probably going to talk with your senior or your attending. I would probably throw the order of heparin in if I was like, this patient has bled before, but I think this is a very large PE. I'm a little worried about this patient. I would put the order in because it still takes time for the heparin to kind of come to bedside, right? So throwing it in and canceling it is not going to harm you, but not throwing it in fast enough may. All right. Actually, let me go back because this is near the end of our presentation. The last thing I really wanted to talk about was like sepsis, okay? Sepsis and what choice of fluids you want to use and things like that. So sepsis, they will trigger code sepsis kind of all throughout. It's built into the EPIC. So if you have a suspicion for sepsis, again, start broad spectrum antibiotics and give them fluid resuscitation. You may be wondering, like, when do I give them that same 30 cc's per kg fluid bolus? I keep hearing about. It's when, if they're hypertensive but they're septic, you don't give it, right? So if their blood pressure is below 90, or if their lactate's like, I think 2 or 4, you're going to give them that 30 cc's per kg fluid bolus, okay? Obviously, everybody kind of plays a case by case whenever somebody has a history of CHF or AKI. But again, early fluid resuscitation will help them a lot. In sepsis, and if I'm meeting any of those, I will probably put on at least 1 liter right away, right? And just get that fluid going fast, and then kind of reassess, is the patient, if they're starting to become if they're becoming hypoxic, and their blood pressure stabilizing, then probably can stop the fluids. But if they're not, if they're still hypotensive and they're becoming hypoxic, then you need probably a slightly higher level of care. And then, and then if they go into, like, if they're becoming not responsive to fluids, right, then you're going to start pressors, like I mentioned, start it through peripheral IV, get it going, and then start early broad spectrum antibiotics. If you're on the nights and you get saying like, hey, this patient's triggering for code sepsis, do you want us to draw all the labs and everything like that? But they're already on broad spectrum antibiotics, it's probably not worth it. It's stupid. Don't draw more blood from the patient, right? But if they were, on broad spectrum antibiotics and then they were initially doing well and now they're like taking a turn for the worse and you're thinking maybe it's still sepsis, then in that situation, I think sometimes it's worth kind of culturing again, just to see if maybe there's some sort of bugs that you're missing, okay? I have these kind of algorithms that are in there. It's on UpToDate, but I put them in here because I know Abdullah's been sharing the PowerPoint with people. But these are kind of approaches that you can go through for all different types of hypotensive episodes or shock. So I just wanted to kind of put that in there just in case anybody was interested. And that's the end. Cool. That was fast. Anybody have questions? Should I go back to the first slide where my contact information is?
Can you go back to the first slide? I just want your contact information shared with everybody. But what I was going to say is there's obviously always a role for albumin on the floor as well. And then if you want to really avoid things, especially if it's somebody that declines ICU admission, there's obviously the role of midodrine as well. But those different things.
Yeah, so if you, and also like even with sepsis or patients that are hypotensive, right? Like if you call ICU and you've just given them like a 500 cc bolus or a liter fluid bolus, the first thing you're going to hear is like, give them more fluids and start midodrine, right? And like, you guys will see this more often when you become like seniors and then you're getting admissions, right? Like the hospital's like, I gave them so much fluid bolus, right? But they really haven't given much. Just give the fluids, start midodrine, see if they can avoid the ICU stay. If they can't, well, shit, you know, call the attending and initiate the ED1 call. Don't page the attending directly, by the way. Initiate ED1 call.